Great. Welcome everyone to the 7th Anne Klibanski Visiting Lecture Series in 2022. My name is Louisa Sylvia. I'm the Director for the Office of Women's Careers and the Center for Faculty Development. In today's session, the University of Alabama at Birmingham's Dr. Casey Azuero will be talking about trauma-informed spinal cord injury care. All right, on to talking about this wonderful award and lecture series. So this was really started as a result of the pandemic, because the pandemic really disproportionately affected women due to the increase in childcare and household responsibilities. And therefore it became more challenging for people to do talks and to travel. And so the Center for Faculty Development started this Scholar Award, which is essentially a virtual visiting professorship to give lectures at a national or international institution. So the scholars who are awarded, who are become AK scholars, receive mentoring, professional coaching, and leadership training. And the award series is named after Dr. Anne Klibanski, who is the president and CEO of MGB. She's also a preeminent clinical scientist who's a former head of the neuroendocrine unit, and has been very successful in receiving external funding for her research, and a strong supporter and advocate for women, and importantly, really established one of our core awards for women faculty at MGH called the Claflin Awards. And now we're going to show our scholars from the past years. This is a collage of our 2020 to 2021 awardees. And this is our awardees from 2021 to 2022. You recognize some of these faces, and then the awardees from this past year. And this is a new slide. You'll see my face on here as one of the champions. I love being a champion. What we do as the champions is we help our scholars to get these various visiting lectures, and also just support them throughout the year. So these are some of the champions who support our women faculty. And last but not least, this visiting lecture series, again, is a part of the Scholar Award, and essentially offers women faculty the opportunity to do talks not only at our institution. We sort of have partnering institutions, if you will, where our AK scholars do talks at other institutions, and then we invite women faculty from other institutions to give talks here, which is the case today with this lecture. Oh, and one last slide here to highlight our partnering organizations for this, and you'll see University of Alabama there is highlighted in red, because that is currently the institution we're highlighting today that we're partnering with. And with that, I'll hand it over to Chloe to introduce our speaker for today.
Awesome. Thank you so much, Dr. Sylvia. My name is Chloe Slocum, and I'm an assistant professor at Harvard Medical School and a staff physiatrist at MGH and Spalding Rehabilitation Hospital. I am thrilled to be introducing Dr. Casey Azuero today. Dr. Azuero is an assistant professor in physical medicine and rehabilitation, as well as a spinal cord injury psychologist at the University of Alabama at Birmingham. She received her doctorate in clinical psychology from the University of Alabama and her master of public health degree from the University of Alabama at Birmingham. She is board certified in rehabilitation psychology and is an associate professor at UAB. Her primary clinical roles include providing inpatient psychological services on the spinal cord injury unit at Spain Rehabilitation Center, as well as providing outpatient psychotherapy to individuals coping with chronic conditions and trauma. Thank you so much for joining us today, Dr. Azuero.
Thank you so much for having me and for that introduction. And I actually had to go look up some of the background about this the series, and I just feel incredibly honored and humbled to be able to be part of this and participate. I've benefited greatly throughout my time as an undergraduate, a contemplator for graduate school, as a graduate student and junior faculty by the mentorship of women. In particular, I'm happy to report, I know there was a little bit of confusion in that intro there, that as of October 1st, I was promoted from assistant to associate level faculty. So this is also very timely for me as I start to work towards my national and international presence as an associate professor. But as mid-level faculty, I plan to continue to have an intention in whatever capacity I can to pay the gifts of mentorship I have received to others as well as trust in and open to the mentorship process that I continue to receive as well. As Dr. Slocum mentioned, I am a psychologist. I'm a board certified rehabilitation psychologist by training and work here. I'm at UAB and Spain Rehabilitation Center. My objectives for the talk, I don't expect for any of us to feel like we walked away as experts in trauma-informed care or to be a rehab psychologist or a physiatrist in SEI, but hopefully just to for you to leave feeling like you've improved your awareness of some common trauma disorders and clinical manifestations, not just seen in spinal cord injury, but anybody really who's experienced trauma. Hopefully maybe feel a little more efficacious in the use of some clinical tools or recognition of trauma disorders, and increased awareness for resources to improve your own level of trauma-informed care with this population. I don't consider myself an expert either. I continue to grow and develop this, what I do believe truly is a skill. And as mentioned, I have no disclosures. So overall, trauma-informed care is kind of more of a philosophy and an approach that sort of shifts the kind of underlying understanding and working with individuals that to sort of have a need to have a complete picture of a patient's life situation, not just in the present, but also incorporating their past into that understanding of who they are in order to provide effective healthcare services. And so it sort of shifts the question from what's wrong with you, or the common question, what brings you to see me today, to what happened to you. So, and all of that is in an effort to realize the widespread impact of trauma and understand paths for recovery. We'll talk about those trajectories later. To recognize the signs and symptoms of trauma in patients, families, and ourselves, and our individual selves and the staff and teams that we are part of. To integrate knowledge about trauma into policies and procedures and practices. And although last, but certainly not least, and maybe most important, is to avoid re-traumatization for the people that we serve and each other as well. So trauma-informed care really leans strongly on communication skills in order to build trust. So delivering care in a language in which a person feels most comfortable, creating a positive and non-judgmental environment. We all have biases, right? Owning that to start with, and being honest with patients and ourselves is key to creating that trust. So trauma overall is an event or a series of events or circumstances that is experienced directly, or thanks to the DSM-5 now incorporates indirect experience and is overwhelming or life-changing. It has profound effects on an individual's well-being, the psychological development, or has physiologic and social or spiritual impact on the individual. When it comes to spinal cord injury, UAB, I benefit from working in an institution that has participated in the spinal cord injury model system since its inception in the 70s. We're also the data coordinating center. So this data on spinal cord injury comes from what we've learned through following people with traumatic spinal cord injury from the time they come into the emergency room until they die or they decide not to participate anymore. So the annual incidence of SCI is about 17,730 new cases in the US every year. And with the chronicity of spinal cord injury as of 2019, the prevalence is about 291,000 folks living in the US. They come to acquire their injury through many mechanisms. Most often, 39% of the time, it's vehicular in nature, so motor vehicle accidents, motorcycle accidents, things like that. Followed closely by falls at 31.8%, violent crime, 13.5%, 8% related to sports injury, medical, surgical trauma, 4%, and then that other non-otherized categorized group is about 3%. We've seen over time that there's been an increase in the age of onset for spinal cord injury. So in the 70s, when model systems first started, the average age of onset was 29. Now it's 43. Disproportionately has not changed and impacting males more than females. 78% of those with SCI are males. And it disproportionately affects minorities, 23% among those with spinal cord injury diagnosis being non-Hispanic Black. So in shifting that mindset from this is what's happening to understanding all that has happened, a patient dealing with new spinal cord injury may also have other experiences that come to the table that are important to understand, as it may make recovering more challenging for them. So the original, there was a study that came out called the ACE study, ACE standing for Adverse Childhood Experiences. It was originally conducted by Kaiser Permanente from 1995 to 1997. With 2 waves of data collection, over 17,000 health maintenance organization members from Southern California receiving physical exams completed confidential surveys about their childhood experiences and their current health status and their current health behaviors. So at that time, childhood being 0 to 17 years of age, the experiences that happened before that age at or before 17 and included things such as violence, abuse, growing up in a family with mental health care, substance use problems, incarcerated loved ones, limited environmental access for advancement, and things like that. And what the data were able to demonstrate was that ACEs matter. And so further studies have gone on to see if, to generalize the data. So about 61% of adults surveyed across 25 states reported they'd experienced at least one type of adverse childhood experience increased to the age of 18 or younger. Nearly 1 in 6 reported they'd experienced 4 or more types of ACEs. The next slide will talk about why that delineation becomes important. So, but we do know there seems to be a cumulative effect for adverse childhood experiences in health and adulthood. And preventing ACEs can potentially reduce many health conditions, and we'll talk specifically about those health conditions that these childhood experiences have been linked to in adulthood. They've also been able to demonstrate that some children are at greater risk than others. Women and several racial and ethnic minority groups are at greater risk for experiencing that threshold of 4 or more types of ACEs. And health economists have been able to put a dollar value and determine that ACEs are costly. So the economic and social cost to families, communities, and society total hundreds of billions of dollars, and estimate that a 10% reduction in adverse childhood experiences for the kids in this country could equate to an annual savings of $56 billion. So persons who had experienced 4 or more categories, I told you we'd talk about that more in detail, really seem to have a much greater stratified risk for many different things, as you'll see in this slide. Some compared to those who had no adverse childhood experiences, those with 4 or more had 4 to 12-fold increased health risk for alcoholism, drug abuse, depression, suicide attempt, a 2 to 4-fold increase in smoking, poor self-rated health, having 50 or more sexual intercourse partners and sexually transmitted disease, 1.4 to 1.6-fold increase in physical inactivity, and severe obesity. So the number of categories of adverse childhood exposure showed a greater relationship to the presence of adult diseases, including heart disease, which you'll see in the chronic health conditions there, column, cancer, chronic lung disease, musculoskeletal fractures, for those of us in PM&R, liver disease. We know now the allostatic load that comes from living in stressful environments accumulates and can manifest as hypertension, obesity, coronary artery disease. And the emotional dysregulation that comes from being in these environments can lead to the risky sexual behaviors that are noted here, the substance misuse, abuse, the mental health issues that they have listed here, depression, anger, aggression is another one, suicide, but not listed, and at least not that I can find linked with this data, is trauma-related disorders, which I would hypothesize as well, because we know the effects of compound trauma. So the consequences of ACEs can be passed from one generation to the next if children don't have those protective buffers, like positive childhood experiences or a caring adult in their lives, opportunities to get out of poverty or harm's way. Also, when families experience historical and systemic racism or living in poverty for generations, the effects of ACEs can add up over time. And psychological research, we know that the genetic impacts that can come from these systemic environments as well. So trauma shapes our worldview, spirituality, identity, right? Like we said, but not everyone is affected adversely. So I don't want to just leave a doom and gloom kind of takeaway, that there are things that can help decrease the impacts of adverse childhood experiences and in childhood as well. But having the ability to get out of living in poverty and good education, social support is key. And I say that for people now, and they're like, oh my gosh, is that depressing working with people with spinal cord injury? Oh my God. I'm like, no, it's really not. Because I get to see people at what they feel like is their darkest hour, and to be able to, for them to find light. And a lot of times that comes from social support. I really believe it can make or break a recovery process. Because that's really who helps us sort of make sense and meaning out of traumatic experiences, and practicing incorporating those events into our personal narrative. So more strategically, where I'm located here in Alabama, you guys may have heard about all the belts that we wear down here in Alabama and this lower southern part of the country. The stroke belt, the heart disease belt, the diabetes belt, the Bible belt, with so many belts. Our accessory wardrobe is full here. And most of the time this is conceptualized because we are in this region of the country, agricultural, more rural in nature. And I even found on you guys' a blog entry on the Harvard Health Publishing talking about how cities can learn lessons from these rural areas, being us here in Alabama, talking about what we've learned from the Rigard study in stroke. But it's not just rural areas. So here at UAB, we're the only level 1 trauma hospital in the state, and we're large. We're the #1 employer in the state. We're a big entity, and we have value-based care and health equity as a directive and a foundation for what we do. And our medical director of health equity has recently been taking a look at our value-based care strategy and utilize data from both our institution at UAB and our peer institutions, and to look at the relationships of social determinants of health, which fall very closely with those adverse childhood experiences that they conceptualized through the ACEs study, to understand health access and outcomes overall. So they, as part of this, looked at the overall vulnerability index, which is a composite score of our population's economic level, educational attainment, access to healthcare based on insurance status, home ownership and living environment, transportation access to parent households, and a lot of overlap there with what we know from the ACE study. And determined either a composite score So one being the least number of social determinants of risk for health outcomes to 5, which is the most. What they were able to determine is that 52 to 65% of the people that we serve live below the poverty line. 24 to 30% are unemployed. 24 to 30%, and that social determinant risk for the darkest green was without a high school education. 24 to 30% without insurance. The life expectancy was 61 to 70 years on average. There was significant food insecurity, meaning that a community of at least 500 people, under 33% of the census tract, resided in areas without close access to a supermarket or grocery store. And also disparities in access to affordable housing. And I would also say something that's not conceptualized in this, but is really important to the population that I work with, is accessible housing. So affordable and accessible housing. And when you look at the map, sorry for all the maps, but I am a visual person and I love maps. And looking right here in the middle, this is Birmingham. This is right where we are here at UAB. This is the greenest area, right where people literally could probably walk to access the wonderful opportunities that we have here, are at most risk for having poorer outcomes and resources overall. So I don't think it's true that it's just the ruralness of our state when looking at these very urban areas. They don't have access to housing and opportunities for employment in very similar ways. So hopefully that helps give some context for more of a developmental model of understanding for these chronic health conditions that are oftentimes considered lifestyle health conditions, that we can make an impact much earlier than when people find their way to us as adults. That impacts ultimately behaviors that we have in adulthood that could potentially lead to going on to experience trauma and trauma-related disorders. So I'll focus on 2 trauma-related disorders today. So that's acute stress disorder and post-traumatic stress disorders. Acute stress disorder, symptoms typically begin immediately or within 3 days and can last up to a month, hopefully declining over the course of that time in a month. Follows very closely with PTSD in terms of the symptoms. Both of them require, an index trauma, so an exposure to an actual or threatened death, serious injury, or sexual violation, either directly by witnessing or learning of the events. So that's also important for those of us that hear other stories to be mindful of, that you can be traumatized just by hearing someone else's story, and your teams can be traumatized in those ways too. So, having that awareness to continue to check in with ourselves and take care of ourselves in this work is really important too. So both acute stress disorder, PTSD disorder require some anchoring traumatic event to have occurred. But like I said, for acute stress disorder, you're really looking at just that acute phase of time of exposure as your differential. But the criteria overall is not much different. It's just more in terms of when those symptoms are happening, and PTSD, as I'll talk about next, has some more specific criteria. But overall, they can include acute stress disorder, post-traumatic stress disorder, can include intrusive intrusions. So those are recurrent and intrusive distressing trauma memories, recurrent distressing trauma-related dreams, flashbacks, and or other dissociative reactions as if the traumatic event was reoccurring, intense or prolonged psychological distress or physiologic reactions that are triggered by those reminders. Negative mood, so this can be the persistent loss of positive emotions, not feeling the full spectrum. Other people just talk about numbness, just feeling emotionally numb. Dissociative symptoms, so altered sense of reality of surroundings or oneself. The inability to remember important trauma details and not due to other causes, medical sedation, things like that. Avoidance. Avoidance of trauma-related memories, thoughts, or feelings, avoidance of trauma-related external reminders. So for instance, people, places, activities. So these are the folks that no longer go to malls or large sporting events, not necessarily because their injury happened in a place like that, but a lot of times it's related to arousal. So hypervigilance being one of the hallmarks of arousal, the more people you add, the more you need to be aware and alert, and that can be really challenging in those situations. And that feeling the need, the fear-based need for hypervigilance can negatively impact our ability to concentrate and focus as well, which can have impact on our relationship. Exaggerated startle response, just touching somebody on the shoulder might, send them into a fear-based reaction that in no way you intended to. And sleep disturbance. Again, we talked about nightmares, night terrors, vivid dreams, that can impact sleep. Other things, again, hypervigilance, if you're feeling the need to get up and check doors or windows or actually survey the perimeter where you live, that can negatively impact sleep as well. But I always tell people, kind of normalizing the fact that if any of us went through something that, had us fearful for our life or witnessed something fearful for our life, we would all likely have the same reactions. The difference between somebody who that doesn't make it, a disorder. But what goes on to help facilitate these trauma-related disorders is I think the hallmark is avoidance. So avoidance of feeling that physiological arousal, avoiding things that bring that fear manifestation on, keeps our brain from being able to habituate to the idea that this happened, not that this is happening. And finding ways to avoid can both be not talking about things, not going places, but it can also be through unplugging from the here and now through the use of distraction or substances, things like that. So it's that psychological stuckness that keeps us with our possibility of, next time I get into a car, I could have an accident, being out of balance with the probability that that's going to happen. Because the last time it happened, I woke up in the hospital, therefore cars are to be avoided. And you guys have the benefit of a great public transportation system, but we don't. And so in this state, your world becomes really small if you don't have access to a car, for instance, after a motor vehicle accident or willingness to get back into a car. So with PTSD, similarly, with that index trauma, you just have to have for a criteria A, that after from a month on, and the symptoms last for at least a month, and include one of 5 or more of the intrusive symptoms, at least one of the 2 avoidance symptoms, 2 of the 7 negative mood states, at least 2 of the 6 more reactive symptoms, and symptoms have to cause the significant distress or impairment in social, occupational, or other important areas of functioning. And obviously, the disturbance is not attributable to physiologic effects of substances or other medical treatments. So collectively, a systematic review of 54 studies looking to find trajectories of recovery after trauma had results that indicated people follow common trajectories of response following major life stressors. And I will tell you that although this is a graph from that study that is general in nature, we have seen this replicated in our population of spinal cord injury, both in this country and in European populations. So we see that if you start at the bottom, closest there to the x-axis, the dotted line is what is conceptualized as the resilient trajectory. These are people that after traumatic events over the course of time have little interference in their ability to function in day-to-day life and the number of trauma-related symptoms that they report. If you go furthest up, people that have a significant amount of symptoms at the onset and really aren't able to recover back to a normal level of functioning after they've experienced a traumatic event or witnessed a traumatic event, and maintain a high level of symptomatology or are considered chronic in the post-traumatic recovery process. I saw this when I was training at the VA with Vietnam veterans in particular. So in working with gentlemen who were coming in asking me, am I crazy? They sort of several individuals I worked with that a similar sort of presentation where they came back from the Vietnam War. They didn't acknowledge the fact that they had been to war, kind of kept their head down. My understanding is that the climate was not very welcoming for our Vietnam veterans in the same way it was for World War I, II in Korea. And so there was even some shame associated with that for some individuals. And so didn't talk about it, got to work, got busy, and then retired and didn't have the benefit of the busyness of life to distract them. And then the manifestation of the symptoms came on. And so we do know now there is a delayed presentation of post-traumatic stress disorder that can even be, decades later. And then the recovery. So those are folks who have high level symptoms. Maybe they got treatment. Maybe they had great social support and coping strategies on their own, and were able to, over time, kind of get their symptoms better managed and get back active into life and the things that are personally meaningful and relevant for them. So I had the benefit of taking part of a committee that has been brought together by the Paralyzed Veterans Association Paralyzed Veterans of America to revamp some dated clinical practice guidelines with folks with spinal cord injury. And I specifically worked with a group on updating what was initially just focused on depression and folks with spinal cord injury. And we broadened that to the management of mental health disorders, substance use disorders, and suicide in adults with spinal cord injury. And in there, we have specific recommendations and guidelines with all of these PVA guidelines focused on general practitioners in the community who may not be a physiatrist or a rehab psychologist or a neurophysical therapist to really help guide and direct you as you encounter folks with SEI. They cover the gamut of secondary conditions, and they are available online. But one of my colleagues in this endeavor is your very own. He's affiliated with both the VA and Harvard is Dr. Sunil Sabharwal. So he was part of this process as well. But overall, for the recommendations that the committee made based on data review and clinical guidance when it comes to trauma-related disorders, are first to screen all patients for acute stress disorder within 1 month of SCI. And again, I think that this extrapolates to anybody who's at risk. And for PTSD after the first month. Specifically, a screening should occur early during initial inpatient hospital or rehab stay as a repeat screen if indicated to assess for persistence of symptoms or change in status. Again, remember that delayed presentation, the trajectory we talked about. At the first post-discharge follow-up point and at future time points beyond 6 months, depending on risk stratification factors, such as being a veteran is one, or other trauma-exposed professional. Again, thinking about their whole story, the number of adverse childhood experiences. We know the impact of compound trauma in adulthood, and especially when it comes to childhood trauma. So hopefully you guys see that as benefit to your understanding now and conceptualization for who's more at risk. And in addition to that, a large multi-site study with over 1,000 participants that oversampled Hispanics and non-Hispanic Blacks reported an overall prevalence of PTSD of 24.9% and significantly higher PTSD prevalence among individuals who were Hispanic at 31.3% and non-Hispanic Black 24.7% than among those who were non-Hispanic white at 19.4%. So again, to have 4 or more adverse childhood experiences, we know that people of color are more at risk. We know that people of color, you understand now that they're more at risk to have PTSD. So also a risk factor, to consider. Second recommendation from the committee was to refer patients with positive screens for these symptoms on to a mental health provider for further diagnostic workup. But if you don't have access, there are some good just general screeners out there. One of my favorites for PTSD is the Post-Traumatic Checklist 5. It follows along with the DSM-5. I love the VA for all things that they do open source, just making it easier for people to be able to access these tools, and this one is. Although no research has really validated ASD or PTSD screeners in SCI populations, this is the best we've got. We know that these are good measures overall. Another good one is the primary care PTSD screen and the acute stress disorder scale at ASDS. In terms of treatment, trauma-focused therapies in terms of psychotherapy for acute stress disorder. Research has demonstrated several meta-analyses showing that early trauma-focused CBT can limit subsequent PTSD. So basically this looks like a 5 to 6 session intervention focused on just general education, learning how to de-escalate that physiology that we talked about without feeling the need to avoid that feeling overall. And then exposing people to things that will increase their hyperarousal so that they can practice those skills real time, and working on some cognitive restructuring. In terms of PTSD, the trauma treatments are cognitive processing therapy, eye movement desensitization reprocessing, narrative exposure, general cognitive behavioral therapy, and prolonged exposure therapy, where cognitive approaches work to correct sort of maladaptive thought patterns, or all or nothing thinking, or that getting that possibility and probability kind of back in balance, while the behavioral approaches aim to decrease the physiological arousal we talked about through exposure to triggering stimuli, after teaching people how to do that effectively. Also teaching people how to work with the cognitions that come up and the emotions that come up, and decreasing the avoidance in that way. by helping them understand that if you don't work on it while you're awake, your brain's going to keep working on it while you're asleep. So coming up with a plan to do so in a way that hopefully doesn't impair their sleep as well. So a big part of that also includes, education and the cognitive restructuring and the exposure. In terms of pharmacotherapy, the recommendation is to offer patients with ASD or PTSD pharmacologic treatment if trauma-focused psychotherapies are not available. It's true across this country that access to mental health care is a huge problem. And so that's a real concern. But also may not be preferred for the individual at that time to even be able to do something, do them both, a psychotherapy approach with a pharmacotherapy approach together. But early administration of hydrocortisone is a promising treatment worthy of additional research. Benzodiazepines may be helpful for acute anxiety, agitation, or sleep disturbance in the immediate period following the traumatic event, but prolonged use may be detrimental for what we talked about, that adaptation, the habituation, and increasing risk for development of PTSD when people can't learn to calm themselves down and to experience the effects of being afraid without having the adverse outcome that resulted the previous times that they had maybe the gunshot wounds or things like that. In terms of, and then obviously other reasons to just think about limiting benzodiazepines during those initial time in the hospital. Patients are also likely to be on opiates, so the risk of respiratory depression also a risk. And then obviously if a patient has a history of abuse, that's always something to consider. For PTSD, strong evidence to support sertraline, paroxetine, fluoxetine, and rifaximin as monotherapies, and fair evidence for mirtazapine, prazosin for nightmares, nifazodone, famotidine, and tricyclic. So I'm hopeful that there was something informative for you all here today. And if you are interested in continuing to learn more about some resources and overall in terms of guidelines for treating trauma, talk to you guys about the PVA's clinical practice guidelines. Those are for folks specific with spinal cord injury. Those are available online. The APA has the PTSD guideline if there are any psychologists or mental health workers on the call that might be interested in seeing more on that. And then I've already sung the praises of the VA. PTSD.va.gov is a wealth of information and resources. In terms of trauma-informed care, if you want to learn more about ACEs and the work that's been done in that way, CDC is your go-to place for resources and that. UAB School of Nursing, if there are any nurses here, if you want to share with your nurses, they did a great mini-con focused towards that audience on trauma-informed care. I know this link would be hard to follow, but if you just Google UAB School of Nursing mini-con, there's two out there, one on sex trafficking and one on trauma-informed care. So that's just a further, 3-hour course on trauma-informed care, like I said, specific to nurses. For physicians, I think Purple Heart Foundation is a great resource to learn more about trauma-informed care. Iowa Trauma-Informed Care Project seeks to educate communities about the impact of trauma on coworkers, friends, family, ourselves who are in the healthcare as well. And they have information on early intervention, self-assessments, and they even host a conference every year. The National Council for Mental Wellbeing, if there's any social workers, they have a mini-con for you guys for trauma-informed care. And for those of you that are more involved in administration and at a systemic level, Trauma-Informed Care Inflammation Resource Center can help lay the groundwork for organizations to adopt the trauma-informed care approach. So I'm happy to take questions and comments from you all. I thank you all so much for coming today. And I just want to acknowledge again, Dr. Yu-Ying Chen and Dr. Karen Miller, who facilitated my ability to be here today. I truly cannot say how honored I am to speak to you all. My co-authors on the PVA guidelines, Chuck Bombardier, Jesse Fan, Don Cow, Scott Richards, and Sunil Sabharwal, and the PVA, and especially Cheryl Vines, who helped coordinate that massive endeavor to get those all of those guidelines up to date, so that folks that are treating individuals with spinal cord injury can do the best they can for them out in the community.
Great. Thank you so much. So sort of like a how-to in so many areas in regards to treating trauma post-spinal cord injury. I have a couple questions. I know Dr. Slocum is also here to help facilitate and ask some questions too. So please feel free to put any questions in the chat to all of us or to either of us individually, and we're happy to bring them up. I'll start with a question and I'll pass it over to Dr. Slocum. I was just curious how much you involve family and caregivers in this process, given the potential for obviously traumatic injury and how you sort of weave that into the work that you're doing.
It is crucial. It is so imperative, right? And obviously, and what I tell people too on the acute side, when I have more opportunity to be right there with family, is what happens. I tell my patients, what happens to you doesn't just happen to you; it happens to those that love you too. And although their experience is different, it can also be challenging. So in order to be the best supporters for the individuals that we work with, we do need to support those that love them, that are probably having their own experience of it as well. But definitely a key part of education and frequency and checking in is really important because, like I said, there is that delayed presentation. So being able to not just have our patients who are probably in information overload, especially in those acute times, but to have their loved ones also help being on the lookout so that they can help bring that to their loved one's attention, or if they go along to medical visits, helping reach out for further support, letting them know what to look for, I think is really important as well. And I do believe there is such a thing as toxic positivity. Sometimes our loved ones, we'll even have go as far as put up signs on the door that says positive vibes only, do not enter if you aren't positive, and just trying to normalize the fact that this is hard and all the emotions are valid and just as they are, and trying to decrease that toxic positivity that I think sometimes we do in our own empathetic distress because it hurts us to see our loved ones cry. So it's more for us than it is for them anyway. And so just trying to educate around normalizing all the emotions and the experience is another part I think that we can all do as well.
That's awesome. Thank you, Dr. Azuero. This has been fantastic. Our colleague, Dave Estrada, has a question about how you see peer mentoring and support groups as promoting trauma treatment and care.
Oh, yes. So we are actually just launching a revamp of our whole peer support program because it is crucial. I in no way pretend to, as someone able-bodied, pretend to have all the answers or even be able to relate on that level with patients. But part of my job is helping support and facilitate them being plugged in with people who, again, although their experience is individual to them, can at least maybe give some hope for the idea that there can be life outside of whatever, new functional status that they have, these changes that may look different, but it doesn't mean that it isn't possible, and to give some hope. And so we've partnered with the Christopher and Dana Reese Foundation because they already had a great virtual training program in place to kind of train people towards SEI peer mentorship in a systematic way. And then we sort of train on our sort of hospital volunteer side. So it takes a lot of investment for our peer mentors, but research has shown that peer mentors also get a lot out of that experience as well. And so we wanted to sort of make it more structured, a little less ad hoc, which is why we partnered with them, but absolutely the benefit of peer mentorship is huge. And anybody who comes in contact across the system can help try to facilitate something like that, even if it's just, the Reeves Foundation may not be somebody, they try to get as local as they can, but people can fill out online forms. But there's a lot, regardless of what disabling condition a person may have that you interact with, there's probably something online for some kind of peer support. So with the people that I work with that experience amputation, there's the Amputee Coalition out there. So there's a lot of good peer support, regardless of what the disabling condition is, that you can help connect people to. Oh, and caregivers also, just to go back to Dr. Sylvia's point, organizations like the Reeves Foundation, they have caregivers that are trained as well to give peer support to other caregivers. As you can imagine, SCI, we see a lot of young, about to launch, emerging adults that are now back at home. And so that also sort of is a mindset shift from where their parents, who are oftentimes their caregivers in those situations, sort of where they thought life was about to go for themselves and their child, and having to kind of regroup that as well. So caregivers can also use support, and there's a lot out there for them too.
I have a question. So I also happen to be a psychologist, and so I'm very familiar with sort of what I call the alphabet soup of therapies: EMDR, CBT, MBCT, right, DBT. And for folks who maybe aren't as familiar with some of these psychotherapies, I was just curious if you had some sort of take-home advice or recommendations for providers who are helping to support these patients and their families after traumatic events.
Yeah, I just would say first and foremost, just listen. Just listen. Sometimes we put this pressure on ourselves to fix, and that's oftentimes not the most helpful thing we can do, because if it had an easy fix that could be encountered in that 15-minute time period you have with the person, they probably would have came to it on their own. And so the greater resource, and we all know time is a resource, right? And our attention, but to give that, I think, goes a really long way. And then just to normalize and validate, I think is truly way more beneficial than any of the alphabet soup of psychotherapies, truly.
So well said. And I love your point around toxic positivity. I think that's so crucial. Like even sort of the like, you'll do great, or you'll be fine, or keep it up. Some of those with even the best intentions, I think can come off as sort of like, invalidating the experience. And this is really hard or really challenging. Even just, again, with the best of intentions, we try and cheerlead, and sometimes that can just be too much. So I love your advice about being genuine and validating where they're at. That's fantastic. Dr. Slocum, do you have any other questions?
I had a question about, so you mentioned in terms of thinking about the team structure, and also just in terms of the definition of trauma, that the team members and the folks who are working with individuals with spinal cord injury in rehab can also be traumatized sometimes by sort of hearing stories or hearing about the experience. I'm curious. I think of rehab as sort of nice because we tend to have comparatively more time to work with people than, for instance, the acute trauma setting. But do you know about any efforts sort of across facilities or sort of cross settings to work with the acute trauma providers as well as the rehab folks?
Yeah, so here at UAB, we have the benefit of an office, what's called the Office of Wellness, but they are a resource for any hospital providers to be able to have just a general wellness check-in or something more significant that may be going on. Our chaplains are also available, make themselves available to all of our providers. In fact, that was really sort of a shift that came after COVID, when they had limited access to patients. They were trying to think about how can, as in their own, I want to be helpful here, what can I do? So a chaplain's actually kind of revamped how they saw their services here and began providing support to the support teams who could get into the trenches when they were being held back at that time. We use pet therapy, or Hand and Paw is our nonprofit here at the hospital, who have dedicated time for anybody who is within the hospital to come and get a dose of oxytocin from the pets that they have. So we have a lot of resources that are general patient resources, but we also have arts and medicine, and we have an artist in residence right now who can turn your narrative stories as a provider into a specific piece of written art for you. So whatever your narrative is, turning that into a poem of some kind when she hears the retelling of your story. So we have a lot of opportunity. And again, I think a lot of this has grown and developed through the time of COVID as we've rethought how we support each other with the high burnout rates that we have experienced here. And I know I'm sure there and all over the country, and for making sure that we're supporting the supporters too. So I hope that you guys have access to a lot of good resources like that there as well.
Well, I think we're running up to the end here, and I just want to thank you for the resources that you did put in your talk. I think that was super helpful and something we don't always do. So thank you for that, and sort of this comprehensive review of trauma care after spinal cord injury. Really appreciate your time today and sharing your insight and expertise with us. Thanks so much.
Thank you all.